All right, so today we have one of our newish faculty members, Dr. Travis Caton, who is an assistant professor of neurosurgery and specifically specializes in neurointerventional surgery. He did his training first MD at Columbia, followed by radiology residency at Brigham and Women's in Boston, and then a diagnostic neuroradiology fellowship at UCSF. He specializes in treating all vascular disorders of the head and neck endovascularly, including stroke, aneurysms, fistulas, venous sinus stenosis, carotid stenosis. And he has done a significant amount of clinical and translational research throughout training. And today we'll be talking to us about pulsatile tinnitus.
All right. Thank you so much, Dr. Morgenstern. Let me bring up my screen here. Let's see. All right. Am I in presenter mode, or can you see my slides normally?
Slides look good.
All right, perfect. Thank you so much, guys. Really excited to talk about this topic, sort of an unusual one, pulsatile tinnitus. We're going to talk about sort of current state of the art in proposed pathogenesis, diagnosis, and treatment of this condition. So I have no disclosures. And our learning objectives, in this talk will be to understand the differential diagnosis for both vascular and non-vascular pulsatile tinnitus, and to understand the complementary role of non-invasive imaging and invasive neuroangiographic studies in the diagnosis and ultimately treatment of pulsatile tinnitus. So I want to start off with an anecdote here. This is a young Edgar Allan Poe, whose one of his most famous stories is The Telltale Heart. And in this story, the narrator describes a sensation of guilt that progresses through the dialogue as he perceives a sound in his ear, which corresponds to a heartbeat. And as you go through the story, there's some really elegant descriptions of what we would now call pulsatile tinnitus. So the narrator describes a sound that's not external, it's an internal perception. And as the story progresses, the sound progresses, and the psychological impact of that sound really drives the narrator insane, to the point where he ultimately confesses his crime. And there's some really, really interesting descriptions of what it's like to have pulsatile tinnitus in this story. And they really are very similar to what patients describe when we talk to them in clinic. Edgar Allan Poe himself has been speculated to suffer from pulsatile tinnitus. People think that the narrator in the story represents Poe and his own battle with pulsatile tinnitus, and his death is still the subject of mystery, but there is speculation that he himself suffered from pulsatile tinnitus and may have been driven to suicide by that. Obviously, that's speculative, but there's a clear impact of pulsatile tinnitus on mental health. And that's borne out in the literature today. We know that patients with pulsatile tinnitus have very high rates of depression. Perhaps more concerningly, they also have high rates of suicidal ideation, higher rates of suicide, and perhaps most concerningly of all, that suicide in these patients tends to occur temporally in relationship to the onset of their pulsatile tinnitus. Beyond the mental health aspects of the disease, there are significant other clinical morbidities that can occur. So we know that approximately 14% of patients with PT, as we'll call it, harbor some underlying arterial or arteriovenous lesion, which puts them at risk of stroke, either ischemic or hemorrhagic. Apart from that population, a significant number of these patients have idiopathic intracranial hypertension, which can lead to papilledema and progressive permanent vision loss. That goes to say that beyond the sort of psychosocial impact of PT, it can actually carry other significant morbidity, and it's not always a nuisance condition. Pulsatile tinnitus is hard to estimate the true prevalence, but we know that up to 5 million Americans have tinnitus, and we estimate that somewhere between 4 and 10% have pulsatile tinnitus. So that would be somewhere between 100 and 500,000 Americans. The community of pulsatile tinnitus, the patient community, is very active and engages with each other and shares their stories. There's a website called Whooshers, named after the whooshing sound that these patients experience, where patients share their stories, often their frustrations with the medical system and their misdiagnosis, but also their victories when their tinnitus is diagnosed. And I really encourage you to visit the website to sort of understand the patient community and learn about what they go through and how they interact with the healthcare system. The challenge with pulsatile tinnitus is that it's sort of left in the gray area between a number of medical silos right now. So ENT, neurovascular specialists like us, psychiatry and neurology. There's really no true home for this chief complaint. What ends up happening to these patients is they end up in one of these referral bases. They end up getting shifted back forth through the different groups. And there's never really crosstalk between the groups to come up with unifying diagnosis and treatment. And what I would argue in this talk, what I'll try to show is that I think that neurovascular specialists can really be the nucleus for a multidisciplinary approach to this condition. So it's important to define what pulsatile tinnitus is and what it isn't. A good contemporary definition is that it is the perception of sound or noise that is synchronous to the heartbeat. That is to distinguish it from non-pulsatile tinnitus, which is continuous and carries a very different pathogenesis, etiology, and management. Again, today we're focusing strictly on pulsatile tinnitus. So I'll start off by talking a little bit about the current thoughts on pathophysiology and the differential diagnosis. First question we have to ask is, what causes pulsatile tinnitus fundamentally? Okay. I think one sort of cohesive definition is that it's an abnormal blood flow pattern transmission to the cochlea. So that can be either from abnormal blood flow generation or abnormal transduction of that blood flow pattern to the cochlea, and perhaps an interaction of those two factors. When we think about it sort of diagnostically, we have to have a structured approach, and there are several different ways to sort of come up with a conceptual framework for pulsatile tinnitus. But the most classic first hierarchy way to differentiate it is into objective or subjective tinnitus. That is objective, something that can be perceived by an examiner, either through auscultation or other maneuvers. Subjective tinnitus being something that only the patient perceives despite any sort of physical or diagnostic tool. We then think about a diagnostic approach. We bucket things as vascular, structural, or sort of systemic etiologies. And then when it comes to making decisions about treatment, we have to think, of course, is this a dangerous condition or something that's benign? We can reassure patients. That distinction is very important. Even if you don't offer treatment, being able to tell a patient their tinnitus is not the source of something harmful is very important for their well-being. So the differential is very, very broad, and that's why this disease is very challenging for all of us. The structural causes include tumors, most notably paragangliomas. It also includes structural abnormalities of the temporal bone, dehiscence of the sigmoid plate, semicircular canal, and otospongiosis, among others. Systemic conditions include medications, neurological conditions such as myoclonus, and then high flow states, including anemia and cardiac disease. But obviously, we're going to focus on vascular causes. Those include venous disorders, arterial disorders, and arteriovenous shunting. One arterial cause that I think deserves a little bit of attention is fibromuscular dysplasia. I mention that because it's something we see almost daily, certainly weekly, in the angio suite. Fibromuscular dysplasia has a sort of a pathognomonic angiographic appearance, more often occurs in women. In a recent study of an FMD registry in the United States, the prevalence of PT in this population was 37%, which is far higher than the standard population. It begs the question as to how and why that occurs. They know in this study that on a physical exam, the patients who had pulsatile tinnitus and fibromuscular dysplasia more often had carotid bruits. So the speculation is that the arterial wall abnormality produces some sort of turbulent flow that's transmitted to the carotid artery at the level of the petrous bone, producing the tinnitus. Arteriovenous fistulas, of course, are the sort of most intuitive cause of pulsatile tinnitus. They're not the most common, but this is clearly due to transmission of arterial pressure and blood flow patterns to the veins. PT may be one of the presenting symptoms in up to 90% of patients with transverse sinus fistulas. It's also very common in fistulas of the skull base, including marginal sinus and condylar canal. On the images here, you see is a patient with a hypoglossal canal fistula that I treated as a fellow. And this patient's only presenting symptom and only symptom at all was pulsatile tinnitus. And that brings me to the final point here, which is that PT may be the only presenting symptom in up to 14% of dural fistulas. So when you have a patient with PT, that may be the only sign or symptom they're going to present with for a dural fistula, which could potentially be high risk for hemorrhage. So going back to the pathophysiology, presumably an arteriovenous fistula creates pulsatile tinnitus through increased pressure, turbulence, and stress along the venous wall. One moment here. And the shunted blood then must result in the transmission of this arterial pulse to the cochlea. That seems more straightforward, but in venous pulsatile tinnitus, it's a little bit less clear. Working along the same lines of what we think causes arterial venous shunting tinnitus, we have to infer that something is causing there to be increased pressure, wall shear stress, and turbulence in the veins. So we'll go through what might cause that. But first, we have to sort of think about what normal venous flow looks like. So unfortunately, there are very few studies of normal dural venous flow in control patients, but of the ones we have several sort of theories as to what that flow should look like. Essentially, it should be laminar or non-turbulent. There should be minimal pressure gradients all the way from superior sagittal sinus to right atrium. And the wall shear stress should be nearly homogeneous throughout, with maybe a few exceptions. One study from my old group in San Francisco looked at 10 controls and found no abnormal flow jets or rotational flow in control patients. This is an example of a flow model of a control. A more recent study found similar normal velocity and flow patterns in control patients. What they did notice was that there is one area that tends to have a little bit higher wall stress on the superior aspect of the distal transverse sinus. And they infer that that's sort of a normal offloading point for wall shear stress in normal physiology. But that's, again, very small compared with what we'll see shortly. Venous sinus stenosis is far and away the most common venous cause of pulsatile tinnitus. There's unfortunately no consensus definition of this. It's very hard to measure and define. It's dynamic. It's largely classified as extrinsic or intrinsic. Intrinsic causes of stenosis would be something like clot or an arachnoid granulation, whereas extrinsic stenosis would be due to typically elevated intracranial pressure, which results in that ribbon-like smooth tapering of the venous sinus that we see in IIH. Some people define it by a pressure gradient. There's various cutoffs. 8 millimeters mercury is one that's commonly used. But again, this is a common finding in asymptomatic patients, but it's much more common in patients with pulsatile tinnitus. And it's extremely common and almost characteristic of idiopathic intracranial hypertension. Flow models show that these stenoses really do result in increased velocity and post-stenotic turbulence in accordance with sort of Bernoulli's law. And that's what we think is a primary generator of tinnitus in this pathology. A related pathology is something called a sigmoid sinus diverticulum, which used to be called venous aneurysm of the sigmoid sinus. These are focal outpouchings at the transverse sigmoid junction. They look almost aneurysmal, hence the name. These have been proposed to be a repository for that post-stenotic turbulent flow. And because they project right into the mastoid air cells, it's believed that that turbulence within this diverticulum is transmitted more directly to the cochlea. Continuing down the dural venous sinus is the jugular bulb. High-riding jugular bulb / diverticulum is sort of a spectrum of the same pathology. Now, this occurs right at the jugular foramen. Here you can see an example from the literature of a normal jugular bulb versus a high-riding jugular bulb. This has been associated with pulsatile tinnitus as well, but it's very common in asymptomatic patients. Flow models have looked at controls and patients with these so-called high-riding jugular bulbs. And basically what they show is that the pattern of blood flow, the velocity of a fluid through the high-riding jugular bulb basically takes longer and results in more turbulence and sort of a helical pattern of turbulence within the jugular bulb that's not seen in patients with so-called normal anatomy. So that brings me to sort of the next cause, what I'll call a venous etiology of pulsatile tinnitus, but this was conventionally thought of as a completely separate entity. That's sigmoid sinus wall abnormalities. These are basically dehiscences, loss of cortical covering of the sigmoid sinus and or the jugular bulb, resulting in contact of the vein with the mastoid air cells and or the cochlea. This has an extremely strong correlation with intracranial hypertension, and more recent studies have suggested that it may actually be caused by pathologic venous flow rather than a separate and independent entity. So what you can see here, the blue dural sinus model, the white part of it is the area of focal bony dehiscence, cortical dehiscence. And what they showed is that in flow models, those areas of cortical dehiscence co-localize almost exactly to areas of abnormal venous pressure. So we're sort of creating a story here where stenosis leads to turbulence, leads to diverticula, leads to bony remodeling, bony thinning. All of these things are sort of in the same spectrum. Now, how do these relate to intracranial hypertension? We know that in intracranial hypertension, CSF drainage, CSF diversion improves clinical symptoms, headaches, papilledema. But we've learned more recently is that CSF drainage actually also improves venous sinus stenosis measurably. This was a study done at UCSF where they took a patient with IIH and did imaging before and after a lumbar puncture. And what they showed was that not only did the venous sinus stenosis caused by an arachnoid granulation improve on an immediate MRI after the lumbar puncture, this was a large volume lumbar puncture, but the caliber of the vein also improved, as did the pressure gradient and the velocity patterns. So this sort of provides a mechanistic link between ICP, CSF pressure, and pulsatile tinnitus. So what we have here is sort of a complex story of interactions between the venous system, the skull, and the CSF pressure. And they communicate and interact with each other in a way that is normal in certain patients and somehow reaches a pathologic feedback loop in other patients, wherein CSF pressure causes stenosis, causes pathologic flow, causes bony remodeling, et cetera, leading to these various causes of venous pulsatile tinnitus. So now I'm going to go through sort of a diagnostic approach to pulsatile tinnitus, including neuroimaging and endovascular diagnostics. But first, I think it's important to look at the epidemiology. Older studies of PT identified venous causes as the plurality as a source of pulsatile tinnitus. But a much more recent study from NYU came to sort of a similar conclusion, but a different interpretation. They identified venous sinus stenosis as the most common cause of pulsatile tinnitus, up over a third in their population of over 200 patients. Whereas in the 2008 study, which is from the ENT literature, it was about 3%. So did something really change here, or are we just changing the way we understand the disease? And I think it's the latter. We're really recognizing that venous sinus stenosis is the underlying cause in what was previously labeled independent bony disorders. In our own experience at UCSF, we looked at 164 patients who went to the angio suite for evaluations. This is a filtered group of patients who had high suspicion for vascular PT. And what we found was that with proper diagnostic workup, we were able to identify a source of pulsatile tinnitus in about 75% of these patients. We were able to rule out the vascular cause in the other 24%. Of the patients with a vascular cause, about half had a venous etiology, 20% had an AV shunt, 7% had an arterial cause. But the most important, I think, takeaway from this study was that 14% of patients in this population had a PT mechanism that put them at a higher risk for either intracranial hemorrhage or ischemic stroke. So again, PT is not a benign nuisance. It can be a symptom of a dangerous underlying pathophysiology. In working up these patients, a good clinical history is important. You want to get an idea of the onset of the pulsatile tinnitus, the severity. You can use a simple 0 to 10 VAS. The laterality can help you localize the tinnitus, and the pitch can be very helpful. I'm going to see if I can play an audio clip of. So this is a patient with an arteriovenous fistula. You hear a crescendo, decrescendo whistling. Very characteristic of an arteriovenous shunt, whereas this is a patient with venous sinus stenosis. It's a much sort of gentler,
I think Travis,
lower pitch. Oh, you can't hear it?
I think
oh no.
If you have your headphones on, it might be going in your headphones. Yeah, try replaying it.
Can you hear now?
Yeah, go ahead. Yeah, try playing it now. Sorry, now we lost audio on you.
All right, can you hear me now?
Yeah, we can hear you.
Let's try this one more time. Sorry about that.
Here we go.
All right, there's your fistula. And this is venous sinus stenosis. So these were actually published on whooshers.com by patients using their own iPhones to record their sounds. So we can actually get much higher quality representations of the sounds using canal microphones as a new technology. It's important in these patients to also establish the impact of PT on their quality of life. There are a number of instruments you can use, and it's important to establish this to guide your own treatment effect and follow up your patients. The one that I think is the best is called the Tinnitus Functional Index. It's brief, well-validated, reproducible, and good, robust to measuring treatment effect. It also correlates with older PT questionnaires that were used in the past. And it's important because it assesses several domains of the impact on quality of life. In terms of physical exam, auscultation has gone by the wayside due to neuroimaging in many cases, but it really helps build a relationship with patients if you listen and try to understand their tinnitus. And you'd be surprised, you can actually hear bruits and hear the tinnitus more often than you would expect. And that really gives patients a sense of validation and trust that you really care about their condition. In terms of physical exam maneuvers, the most common maneuvers are designed to increase or reduce jugular venous flow to identify that as a venous source. So if you compress the jugular vein or turn your head toward the side of tinnitus and the tinnitus improves, you're basically redirecting blood down the contralateral jugular vein, reducing blood down the symptomatic side. If this tinnitus improves, that suggests that that there's a venous cause, and B, that it's ipsilateral to the side you're compressing. Conversely, if the tinnitus worsens with compression of the symptomatic side, it suggests a contralateral venous etiology because you're redirecting flow to the contralateral side. Valsalva is also a non-specific technique, but changes in tinnitus from Valsalva also suggest a venous etiology. There's actually reasonable data that the jugular compression technique is very helpful. And some people suggest that it has a sensitivity and specificity approaching 80–90% for delineating a venous cause of pulsatile tinnitus. So it's very, very helpful in the clinic in differentiating venous from non-venous pulsatile tinnitus. Audiologic testing is helpful as a baseline through ENT. This includes standard testing, as well as something called transcanal recording, which I was alluding to earlier. Rather than putting an iPhone by your mastoid process, they put a small microphone that's dampened into the ear and measure directly the sound in your external auditory canal. And you can create these frequency maps here, which correlate with the sound patients hear, and it also correlates with treatment effect. So that's one way of objectively measuring the impact of your treatment on a patient's pulsatile tinnitus. It's also important to identify conductive hearing loss, which generally indicates enhanced perception of sound, can be seen in otospongiosis, and sensorineural hearing loss, which could cue you into the presence of a tumor. Again, it's important to try the best you can to identify the patient's sound, because identifying the pulsatile tinnitus that's been told it's in the patient's head really helps you build rapport and trust with that patient. All patients who have any suspicion for IIH in this population should undergo a workup for the modified Dandy criteria for IIH. That includes a lumbar puncture, And it should also include a formal neuroophthalmologic assessment, including fundoscopic exam and perimetry. As Dr. Betterson alluded to in the chair's corner, many of these patients won't actually perceive their vision loss until it's too late. Automated perimetry can identify subclinical vision loss and help you steer the patient towards treatment and potentially prevent permanent vision loss, which can happen in a matter of weeks in foment and IIH. So this is my approach to neuroimaging PT. It's an MR-based approach that I used at UCSF as a fellow. It consists of 7 sequences on MR. This was built over years, and it's tailored specifically for the evaluation of pulsatile tinnitus. It includes a 3D T1 sequence, a diffusion-weighted image, 3-dimensional flare, time-of-flight MRA, an arterial spin labeling sequence, and something called a TRIX, which is a time-resolved contrast kinetics sequence. Essentially functions like a MR angiogram where you visualize flow in the arterial and venous phase. And then most importantly, I think, is a gradient 3D T1 fat saturated post-conscious state. There's a lot of neuroradiology jargon, but notice we don't have MR venography on here. We use post-contrast T1 weighted sequences to look at the dural sinuses. We find it to be much more reliable than conventional MR venography. So in terms of your differential diagnosis, the temporal bone CT is the diagnostic tool of choice for patients with any sort of auditory abnormality, and will identify the bony structures far better than MRI. But I would argue that MRI and MRA in this protocol really hits all the rest of the differential and is therefore more effective as an initial imaging modality. The strengths are that it's very sensitive for venous pathology, shunts, and arterial disease, as well as tumors. It can be done in about 25 minutes and it doesn't have any radiation. The disadvantages are obviously evaluation of the bones and middle ear and inner ear structures. It requires 3T scanner and some specialized sequencing and protocoling, which can take additional work. This is an example of ASL, arterial spin labeling here, showing arterialized spin in the jugular bulb and also the transverse sinus. Those were all patients who were found to have dural fistulas. And this is an example of the TRIX sequence, which is a really beautiful evaluation of the entire venous anatomy, again, using a contrast enhanced sequence. And this was a patient with Eagle syndrome, impingement of the jugular veins by venous Eagle syndrome by the styloid processes. So the endovascular workup for pulsatile tinnitus for me includes diagnostic arteriography to look at shunting and the global venous sinus dominance. It also includes venography and venous manometry. So venous manometry involves measuring pressures at different points throughout the dural venous sinuses and measuring pressure gradients. This is a template I use that's very, very comprehensive and basically identifies any source within the dural venous sinuses that could potentially be a site of a pressure gradient. For patients who have really conflicting causes of pulsatile tinnitus, some patients will benefit from something called a venous balloon test occlusion, which I'll talk about. That can help troubleshoot and localize the sound generator on the venous side. When we do this with patients, we ask them to score their pulsatile tinnitus 0 to 10 as we do the balloon test throughout the dural venous sinuses, and we look for changes with the patient being blinded to where the balloon is at any given time. So it has to be a very objective test. So the concept of the venous balloon test occlusion is that we inflate a balloon at different points in the venous sinuses to look for stenoses, but also structural abnormalities like diverticulum. And unfortunately, we don't have test characteristics to know sensitivity and specificity. I would think that the specificity is fairly high. I think the sensitivity is probably fairly low, but when you're troubleshooting a difficult case, it can be very useful. So if you have pulsatile tinnitus on one side with a sinus stenosis, you inflate a balloon in the contralateral transverse sinus, you're effectively redirecting flow through the stenosis. You would expect a patient to report an increase in their tinnitus during the examination. That's one example of how this could be used. Another would be if you had contralateral conflicting potential sources of tinnitus and you weren't sure which was the cause. In that case, you can inflate the balloon at different places and ask the patient to report differences to determine which lesion you might treat. This is an example of a patient who had a jugular bulb diverticulum on one side, but a transverse stenosis on the other side. The patient's tinnitus got much worse when the balloon was inflated in panel D in the left-sided transverse sinus because flow was directed through the stenosis and resulted in increased condylar venous flow. That helped us identify that the jugular diverticulum was likely not a cause of that patient's tinnitus. So treatment approaches. In general, with the proper diagnosis, in our experience at UCSF, we could be pretty successful in treating pulsatile tinnitus endovascularly. In the case of AV fistulas, we had a greater than 95% long-term durable resolution of PT. For patients with IIH and venous sinus stenosis, still a very good, long, durable result in pulsatile tinnitus. The key is identifying and diagnosing and selecting your patients properly. So this is a treatment algorithm we used. Suspected vascular PT should always be assessed for a lesion that could potentially cause a stroke, ischemic or hemorrhagic. That obviously should be treated immediately. With no stroke risk, the next question you ask, is there any chance this patient could have IIH? If there is any chance at all, you should diagnose it, work it up, start with medical management. If the patients fail, then they're candidates for stenting. If they don't have IIH, you need to determine with the patient if the PT is debilitating. If the PT is debilitating and it's a benign cause, they need to understand the risks and benefits of potential treatment. If it's tolerable, they may be reassured by knowing that it's not something potentially harmful. They might be okay with observation. Venous sinus stenting is the most well-described treatment. There are several flow models that show that venous sinus stenting restores that physiologic flow across the stenosis. And one prospective study shows extremely high rates of PT resolution. And this is in patients who were treated just for PT, not for IIH. This is an example of a venous sinus stenosis with a stent deployed and a resolution of the normal caliber. Embolization of venous structures is also described. The sigmoid sinus diverticulum was first reported in 2000 by the French in a patient with debilitating PT who was found to have this large venous diverticulum. They treated it like an aneurysm and found the patient got remarkably better. And that really sort of brought the concept of treating these as a source of pulsatile tinnitus. Mastoid emissary veins can develop often in IIH. When they course along the mastoid air cells, they can be a generator of PT. These are much more ambiguous. In the case reports, they're always successful, but in one series where there were a number of failures, they basically concluded that these are common incidental findings, but you really need to localize them as the cause before you offer treatment. The treatment risk is low, but you don't want to treat something that's not the cause of PT. The most challenging lesion is probably jugular bulb abnormalities. These are these lesions right at the jugular bulb. They're essentially like wide neck type aneurysms in terms of morphology. These are classically treated with surgical remodeling, but there are many reports now of coiling of these lesions, often with balloon assistance or even stents. There's even one report of a web device used to treat one of these lesions with good results. I would caution, though, that putting stents near the jugular bulb has historically carried high risk for stent migration. Not for this indication, but for others. The stent can migrate into the jugular vein and ultimately into the right heart, which can be a catastrophic complication. So this is something you want to undertake with significant caution. This is an example of a stent-coiled jugular bulb diverticulum. Non-surgical therapies, largely from the non-PT literature, include tinnitus retraining therapy, cognitive behavioral therapy, transcranial magnetic stimulation. These have all been studied in general PT with randomized trials. They're all fairly effective. Transcranial magnetic stimulation may not have a long-lasting effect, but this is a good resource for patients who don't have a treatable cause. That 25% in our population that we don't ever find a treatable cause, but the patients are still debilitated. So in summary, we sort of went through the differential diagnosis of vascular PT. We talked about one concept of pathogenesis of venous PT and its relationship with structural abnormalities and CSF pressure. We discussed a sort of diagnostic approach to PT, including a neuroendovascular evaluation. And I talked about a few treatments that can be offered. And then my conclusions here are that PT has major adverse effects on mental health and may indicate an underlying dangerous lesion. So it's an important chief complaint to take seriously. Venous PT is likely the most prevalent subtype. The diagnosis is very challenging. It often takes persistence and an organized, systematic approach. endovascular treatments are likely effective in many, many cases, but a multidisciplinary approach is really best for patients. What I showed here was a PubMed search in JNAS for pulsatile tinnitus, and you can see the increase over time in articles talking about pulsatile tinnitus, which I think reflects the shift towards our subspecialty in being the nucleus for care for these patients. And I think that will continue to increase over time. So with that, I want to thank everybody here at Mount Sinai, the Department of Neurosurgery, my whole team for welcoming me to the department. It's been a great experience, and it's really an honor to be part of such an incredible group. I want to thank my crew from UCSF who trained me, and also specifically Dr. Amons and Dr. Meisel, who established a pulsatile tinnitus clinic at UCSF now almost a decade ago, and were really drivers in teaching me to think critically about the veins, but also about how to interact with and think about these patients with pulsatile tinnitus critically. And with that, I'll open up for any questions.
Thank you, Travis. That was by far the best presentation on this topic that I have ever heard. And it's just fantastic. I have so many ideas of how we can help you build this in the New York area. And I just think it was great. I would just like to ask residents, what was your favorite part of Travis's talk? Frank, what was your favorite slide?
Where we the high risk of putting in venous stents. It seems like a very, very high risk of complication that migrates to the heart, like you said. I kind of like the, I guess, the danger of that. Yeah, that's my favorite part.
Halima, what was your favorite slide?
Wait, can I make a comment on that real quick? This is Jay. First of all, Frank, I think that's really an insightful comment. And the other aspect is, I do want to say that this is a field that's been growing and changing as a general comment. And actually what we've learned in recent years is that it's not high risk. It's really become, so I'm not sure, I didn't take that from Travis's, maybe it's because of my background knowledge that I have. So maybe there was, maybe I was influencing the way I was interpreting what he was saying. And just so the audience knows, we actually know it's very not high risk. In fact, this is unpublished data yet, but it will be published as part of an FDA prospective, core lab and independent adjudicated trial, that the complication risk was essentially zero in a prospective trial like this of, I can't remember, it was like 48 patients or 50 something patients. One patient had a GI bleed from the aspirin and Plavix, which was managed. And if you scour the literature, there's actually almost nothing in terms of complication percentage. So obviously complications happen with anything, but the rate is extremely low. Travis, I'd welcome you to comment on that. I just didn't want that concept to get perpetuated. No,
I don't want to perpetuate it. What I was alluding to was not so specifically treating jugular bulb abnormalities, but there was a period of time where there was enthusiasm about stenting the jugular veins proper. And about 10 years ago or so, it was believed that could help treat multiple sclerosis. There was some movement to stent jugular, but this is now talking about the jugular vein proper. There were some incidences in that literature of stent migration to the heart that led to that practice sort of dissipating for other reasons as well. With respect to landing a stent within the skull, I think the risks are probably more comparable to dural venous sinus stenting, which we know is fairly safe. The challenge is sizing the stents, et cetera. But I agree with you. I think the risk is considerably lower than what was being done before in the cervical jugular veins.
Travis, go back to your slide 15.
Sure. Can you see my screen?
No, you got to reshare.
Oh, I got to reshare. One moment.
it up, I would say that we were as a center not particularly aggressive in then adopting sort of approaching and thinking about venous disease processes. In fact, the MS one was a cautionary tale. In fact, it's a credit to the neurointerventional space. Adnan Siddiqui ran a trial which showed that it was not beneficial.
Right.
There were a lot of shucksters out there doing a lot of crazy stuff for that. But
that's what I was alluding to.
We've been slow to adopt it because of our lack of clarity about the safety. But as the safety data has grown, our comfort level has increased. And just one last comment before we move on, and this is for the residents. What Travis has done with having this knowledge base and expertise, going to a place to do his fellowship where they were doing something that was very cutting edge and where he came away with a specific skill set, is exactly what I'd like to encourage for you guys to do. Travis is a completely outstanding human being in and of his own right. And for that reason, we'd love to have him on our team, but he was particularly attracted to us specifically because he was coming from a program where he had extensive knowledge and background in this sort of stuff. And he was bringing a new and unique set of skills and insight to our team. And so I would encourage all of you as you're going and looking at your fellowships and thinking about what you're doing, thinking about doing it in the context of, you can bring a unique skill set to your place. So anyways, I'll stop with that. You go to the slide, Dr. Betterson.
No, why do you think this is my favorite slide of his presentation?
For a variety of reasons. We know
No,
that
there's only one reason. There's only one reason.
Okay, you love anatomy.
No.
Okay.
Why is this the most important slide for the residents of this presentation? Emily? Ray?
I think it could potentially be an important cause of pulsatile tinnitus that we don't always think about.
No. It's because he saved this case from his training. This was a case that he did during his fellowship. And he kept track of every single case that he did while he was learning. And here he is now, an attending in our neurosurgery department, showing what he learned as a fellow. So you know how often I've asked you to please keep track of what you're doing. So this is like the foundation of a full knowledge base. If you can only take one thing away from this talk, you should take this away. That what you're seeing now will stay with you, hopefully, and so you should pay attention to what it is. Sorry, I really wanted to get that point across, but please go ahead with. I'm sure people have other questions. Travis, 14% of your cases had a high risk angiographic, high risk of some sort of lesion. Was that all patients with pulsatile tinnitus?
No. That's the subset of patients who have been filtered down to the point where we wanted to undertake a neuroangiographic evaluation. So that what I would say is that's in patients with suspected vascular pulsatile tinnitus. There's a larger number of patients who come in who have other etiologies or non-pulsatile tinnitus. So I would say that what that number reflects is patients who we believe have a vascular cause based on their neuroimaging, their non-invasive neuroimaging. And then they went on, that subset of 165 patients were ones that we brought to the angio suite for diagnostics. So in the global picture of pulsatile tinnitus, that number would be lower. but I would say it's a reasonable estimate in patients with the vascular subset of pulsatile tinnitus.
And just to summarize again, what percentage of patients with pulsatile tinnitus will have a vascular etiology?
Approximately 75%, 75%
On DSA.
on a DSA evaluation.
DSA.
That includes the arterial, the arteriovenous, and venous abnormalities. Yeah. So we're still, and this is pretty consistent over time. There's still about a quarter of patients, a quarter to a third of patients who we really cannot land on a diagnosis. And I think that just requires, more work. That number seems stable, but again, we've had a shift in our understanding of the condition in the last 10 or 15 years. So more work to be done. It could be something, more physiologic, flow of endolymph. There's hypotheses about CSF pressure affecting endolymph currents and things like that. So there are other potential mechanisms that wouldn't be captured by an angiogram.
Hey, Travis, I thought that was really exceptional. I didn't know that you could measure objectively pulsatile tinnitus before and kind of grade it objectively. I think that's extremely valuable. Is there a discussion about on the tinnitus scale you showed about what's acceptable to treat or not, or does it really come down to the patient's subjective assessment of how annoying it is?
Yeah, that's a really good question. In terms of thresholds, there aren't really good thresholds that are defined. So the index I showed, the tinnitus functional index has there's another one called the tinnitus handicap inventory, and it gives you buckets like mild, I forget what they are, but I know that the highest one is literally called catastrophic, where if you get a certain score on the the instrument, I thought catastrophic was a little bit of an extreme term, but basically it's going to come down to how debilitating it is for the patient's life, and what the anticipated risk of treatment. If you have something you can treat easily and safely, a diverticulum, for example, or even a venous sinus stenosis, and the patient's really debilitated, they're scoring off the charts on their screening questionnaire, then I think you have that conversation. I think it really is patient dependent. There are a lot of people who will feel that they can live with it, that they don't want to stomach the risk of any procedure. But if they know that it's not going to cause them harm, you've effectively rolled out all the harmful things, including IIH, then they'll be happy with that. And I think that's important as well. So there's no specific threshold, but some of the tinnitus questionnaires do stratify it into buckets, which can be useful.
I was also, you were talking about the balloon test occlusion. It seems like if you blocked any point along the transverse and the sigmoid, you would also alter the flow along the rest of that vessel. Is anyone doing temporary stenting where you put up a stent retriever and allow the flow to continue?
I was going to talk about that at the last minute. I cut the slide. So there's really not much in the literature about that. I know Dr. Mako has experience with that. With the Komanichi, I think it's a really interesting strategy, right? You can essentially simulate what the flow would be like with a stent, right? And if you can eliminate and even temporarily angioplasty the stent and the patient gets much better, that really gives you ammunition to counsel the patient about venous sinus stenting. But there's really no literature on it so far.
So yeah, we're writing the first report of it. Maze is, the draft is pretty much done. She's just selecting the images. So
yeah,
I think that's the way it's going to go.
Yeah, no, I think that's. I mean, that tool wasn't even around, when I was a fellow at our institution. But I really think it really is, like you said, will I think become potentially the tool of choice for troubleshooting these things.
We've got two questions in the chat here. Dr. April asks, if it's a fistula, does that mean it's unilateral pulsatile tinnitus?
More often than not, unilateral AV fistulas will cause unilateral pulsatile tinnitus. We do see, I would say, bilateral pulsatile tinnitus is more characteristic of intracranial hypertension, venous sinus stenoses. In general, unilateral pulsatile tinnitus is the way it presents for a dural fistula. However, there are some people with really high flow shunts and a lot of redirection of blood across the to the contralateral condylar veins, like across the skull base, who will sometimes have bilateral PT, even though the shunt is on one side. But yes, more often than not, it's unilateral in AV fistulas.
Then Dr. Jenkins is asking, what's the long-term efficacy of stenting for venous eagle, considering repeated trauma from the thyroid to the stent?
Venous eagle, that's a really good question. I don't know the answer for that. I would say that, our practice was, again, a little bit of caution from the literature of jugular venous stenting, which we alluded to earlier. I think the mechanical impingement of the styloid and or C1 tubercle is less likely to respond well to a stent than surgery. So we in our practice, we wouldn't stent those. We would refer them for a styloidectomy. There are reports of it, but I don't have good data on that. My speculation is that it's not going to be as effective as surgery.
Travis, do we do transcanal recording it here?
I would like to find out. So it's relatively simple from a hardware standpoint. It's more of the post-processing that I think takes a little bit more. But I would love to talk with the ENTs about that, because it really is, I think, the way of the future. A stethoscope is one thing, but I think if you can really show, I took out a slide I had when in an AV fistula where the transcanal recording looked like a Doppler of an artery, the same waveform. So you can really, and that was in an AV fistula. So you can really characterize, and more important than that, you can show pre-post treatment changes in an objective way. So I would love to investigate setting that up here.
Well, I definitely would like to connect you or get you connected. You may have already met Maura Cosetti, and also Joanna Jen, MD, PhD in neurology, who runs the Ontology and neurogenetics program. There's a lot of depth and breadth at Mount Sinai, but as always, it's kind of spread out, and I'm sure that you could organize it.
Yeah, one other note on that is we have sort of put together a little bit of a task force with a few of the ENT surgeons that have, in the last while sent us some cases, and we're sort of talking about how we can best coordinate and organize a process. So Travis, Chris, and myself did a call with 3 of the ENTs, and we're trying to work through that as well. If there are additional contacts, like none of the people you just mentioned were part of that, so that would be helpful for us to figure out. So
That is
Travis, let's follow up on that.
great.
Yeah, for sure.
Great.
All right, we're at 9 o'clock here. Thanks so much, Travis.
Right. Thanks, everybody.
Thanks a lot. Great presentations.